Good morning, everyone. Welcome to the COVID-19 Community of Practice for Ontario Family Physicians. My name is Ali Damji, and I'm a family physician at the Credit Valley Family Health Team and Division Head of Primary Care at Trillium Health Partners, and I'll be the moderator for today's session. We're really excited to bring to you COVID updates and ChatGPT, two topics that are very near and dear to our hearts, and also something that's very topical. So we're really looking forward to sharing with you today different knowledge about these topics. Next slide, please. So we have a great panelist of people, a great panel of people who will be presenting to you today, and really looking forward to having your engagement today. Just a reminder, the COVID-19 Community of Practice is an accredited program as well. Next slide. I'm going to turn things over to Mehle for the land acknowledgement.
Thank you, Ali, and good morning, everyone. It's really nice to be here. As Ali said, we've got a really interesting session lined up, and I'll just take a moment to thank our panelists before we get started. So moving on to the land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinanton. Next slide, please. So just a reflection on our land acknowledgement. This was an interesting article that was out a couple of years ago about Victoria Day, and it highlights a values-driven Indigenous technology firm based out of BC. So the owner, who you can see here, his name is Jeff Ward. He's part Métis and Ojibwe. And in an effort to foster a more diverse workplace, he's chosen an approach within his organization where he provides his employees with the option to take days off that are not stat days, so days in substitute for the standard stat days that we know are rooted in European tradition. So he typically works on Victoria Day and Canada Day, and then he takes off the spring equinox and the winter solstice. And the way he sees his company's approach is more of an intentional act of decolonization. So for me, it just reminded me that there may be things that we've always done a certain way in our workplaces, and it might be time to rethink how we do things, or there may be room for improvement, whether that relates to how we're approaching patient care or how we're managing and supporting our own staff. Next slide. And back to you, Ali.
Thanks so much for that. So in terms of today's session, as I mentioned, it is accredited. And in addition to that, the previous webinars and all the related resources are all posted online on the website, and they will be circulated from today's session as well, following the session. We also have our planning committee, and I just wanted to briefly thank them as well, too, for all the work that goes into planning today's session. Next slide. And so I'll be introducing the panelists shortly, so we'll turn to the next slide. So first, we'll start off with Dr. Susie Hoda.
Good morning. My name is Dr. Susie Hota. I'm the Medical Director of Infection Prevention and Control at University Health Network and an infectious diseases specialist. And as of June the 1st, I'll actually be the division head of infectious diseases at UHN and Sinai Health. I have no other disclosures except that I did receive an honorarium here for this talk. Thank you.
Congratulations on the new role. That's exciting. Next, we'll turn things over to Anne Dabrowski.
Hi, good morning, everybody. My name is Anne Dabrowski. I'm the Director of Information Services at the Center for Effective Practice and a practicing medical librarian. And I have no other disclosures except for the honorarium for today. Thanks so much.
Thanks, Anne. Next over to you, Ian.
Hi, I'm Ian Pun. I'm a family doctor in Scarborough Health Network and administrator of Oscar EMR website. My disclosures are just I get honorarium for today, and I get speakers fees from a handful of pharma companies.
Great. Thank you so much. For myself, I receive honoraria for being the moderator for the COVID-19 Community of Practice. Over to you, Melanie.
Thanks, Ali. So my name is Mehle Kuminen. I practice in Cambridge, and I do receive a stipend for my role as the president of the OCFP, as well as the chief of family medicine at the Cambridge Memorial Hospital.
So just some housekeeping items to remind everyone of how to engage in today's session. So there is the Q&A button, and you can use the Q&A function in order to put questions. And I see some of you have already been very keen and put in some questions already, which is great. Please remember that you can upvote other people's questions, and that brings them to the top of the list. So that way, as the moderator, I know which ones are the most popular, so I can ask those questions first. So please make sure to take a look through those, and rather than duplicating questions, if you see one that was what you were going to ask, just upvote it. For the chat box, you can use that for networking purposes and for discussing with one another. But please, if you have a question, put it into the Q&A. It makes it a lot easier for me to track it versus if you put it into the chat. Next slide, please. All right, so in terms of the order of presenters, we'll start with the COVID-19 update from Dr. Hota, and then we'll turn things over to Anne and Ian for the ChatGPT section. Next slide, and over to you, Dr. Hota.
Thank you so much. Good morning, everybody. So the purpose of my brief discussion today is really to give you an update on the current state of the pandemic in Ontario today. I'm not really going to be focusing on anything in terms of clinical management, but really about where we are today in terms of preventing transmission of COVID-19, what sort of our pandemic measures look like, and what the epidemiology is saying to us. Next slide, please. So you may have been aware that on May the 5th, the WHO had convened and made a decision that the COVID-19 pandemic no longer fit the definition of a public health emergency of international concern. Now, this doesn't mean that the pandemic is over. I think we all kind of know that, but what exactly does it mean? And I think this has been interpreted by people in various ways. And according to Dr. Tedros from the WHO, what it means is that it's time for countries to transition from emergency mode to managing COVID-19 alongside other infectious diseases, because we know that there are many other priorities that we have as well, and we need to get out of this constant responsive mode and more into preparedness and managing things more feasibly. And we know that deaths have been trending down. A lot of these decisions were based upon what the impacts of the pandemic have been globally. But a point was made during the press conference for the release of this information that we're still seeing 480 people die per day at least. That's what's documented. And so this is still something that's got impact. It's just no longer considered emergency. So next slide, please. What have we been seeing here in Ontario? This is a brief update of what the case count estimates would be reflected by testing and percent positivity by surveillance week. This is data that's all very easily available through Public Health Ontario. And you'll see that in the sort of larger graph with the blue bars and the line, the trending line, the percent positivity of those who are actually getting tested has significantly decreased over time, and it continues to kind of trickle down at a slower pace now. And one thing to keep in mind is if you look at the blue bars, which reflects the number of tests that are actually being completed week to week, that's been decreasing as well, as we know, as PCR testing eligibility has been also more limited over time, and people are tending to not come forward for PCR testing. That tells you that with the percent positivity still decreasing, we're in a relatively confident place of saying that overall case counts have been trickling down. And that's also reflected by the wastewater signal data as well for Ontario as a whole. And you can also find on the website for Public Health Ontario a nice report that shows you regionally what's happening with wastewater signals. Next slide, please. If we think about indicators of severity of COVID-19 infection, which are usually captured by hospital admissions with COVID-19 as well as deaths in Ontario, these two have been decreasing. And you can see that quite nicely with the hospital admissions data, which doesn't really discriminate between if people are admitted with COVID-19 or for COVID-19 infection. So overall, the counts have been coming down for several months now. And the same with death counts, which, kind of peaked with Omicron and then just have come down again since then. Next slide, please. Now, we can't talk about the pandemic without considering other respiratory viruses, because the pandemic itself has had an effect on seasonal respiratory viruses, which have behaved differently from what they normally do in the past 3 years. So let's talk a little bit about influenza positivity. We did have an influenza surge this year. It happened earlier than usual and didn't peak as high as we typically would see with an influenza season. So it's not quite behaving back to normal, so to speak, but we were lucky enough to escape without too much harm or damage from influenza this past year. And since about January, we've seen very little of influenza A, and influenza B never really reared its head and had a peak like it typically does after an influenza A wave in a seasonal kind of distribution. So very little influenza B has been circulating as well. Next slide, please. So with all of these changes in the epidemiology of respiratory viruses and the overall situation in Ontario looking much better over the spring, Public Health Ontario back on April the 11th released this update. It's interim measures for infection prevention and control based on what the transmission risk is in healthcare settings. And a lot of this is quite geared towards hospitals, but I would say that it's translatable to all settings, healthcare settings. So please do take these recommendations and consider them as you would use them in your office practice, very similarly to how we would do this in a hospital setting. Next slide, please. The approach that was taken in this is really categorizing the situation epidemiologically as either a high-risk period or a non-high-risk period. Now, this sounds very vague, but I think we all understand that you can't really put specific numbers or parameters around how we define high risk and lower risk or medium risk. It was becoming just not really tangible for people to have those kinds of categories. So there are some footnotes at the bottom of these tables that do help people to understand how you could actually determine what situation you're in. But essentially, if you're in a surge type period that's looking like it's going to last for a while, you'd be in a high risk period. And otherwise, you'd be in a non-high risk period. And a lot of the recommendations are focused around how do you deal with masking in healthcare settings. And you'll see that the recommendations really loosen quite a bit when you're in a non-high risk period, which we would argue we've been in now for several months within Ontario, and which, a lot of the decisions are situational and not necessarily a recommended or a strongly consider for use, even in areas that are clinical. So a lot of discussions occurred here, and I will say it was quite controversial for them to kind of arrive at some of these recommendations, but the idea is to give flexibility so that people can use judgment as to what's happening regionally and then be able to implement changes in these longstanding pandemic response measures we've had in healthcare settings. Next slide, please. So in Ontario, we've taken a regional approach to try and coordinate how healthcare settings, and this is very much focused on hospitals, but like I said earlier, I think that this ends up being translated to other settings as well. And so in the Toronto region, which is where I am, we have a committee called the COVID-19 Hospital Operations Table that has put out implementation-focused guidance for hospitals in the region. And we have been reviewing our pandemic measures since the middle of February as things kind of stabilized out epidemiologically. Next slide, please. And so this just really, I'm not going to go through every iteration of what we've done in the last few months, but it does show that we have made changes to our recommendations on February the 28th, then again on March the 22nd. And then finally on April the 11th with that release of the Public Health Ontario document, which is much more permissive in us looking at our situation and deciding what to do with our pandemic measures. And in the first iteration of changes on February 28th, a lot of the focus was removing physical distancing requirements, which we know are affecting our operations. Really we're not able to implement that effectively in many parts of a hospital at least. And I would argue also in clinical office practice, it's very difficult to keep that going, as well as loosening up visitor restrictions, for example, and those kinds of things. And we didn't want to touch universal masking while we're making those changes early on, still in February, without giving it a little bit of time to watch what was going on. And so the one change that was made back then was that offsite, non-clinical or non-patient facing areas or departments, like your finance department that may be in a different building from the rest of the acute care hospital, for example, those areas could actually make masking not mandatory, but still recommended or still offered to people in a mask-friendly environment. And then when the second revision was made to some of our measures on March the 22nd, we actually didn't touch the universal masking recommendations at that time. But most recently on April the 11th, we have made some other additional changes. And again, this is reflecting the Toronto region, and you will see that other regions within Ontario have different recommendations as well. We've diverged a little bit, which is unfortunate, but the reality of how things sometimes work. And so the way that we're approaching it currently is in all clinical areas, like, hospital units, clinics where patients are seen, and public areas like elevators and hallways and lobbies within our hospitals, masking remains mandatory. However, in the non-clinical, non-patient facing areas or the clinical departments like pharmacy, where again, there's not patients involved, they are no longer required to wear masks, but again, it remains a mask-friendly environment. So that's where we're standing right now. And I will say that we're actually at this moment, having discussions still to see what will be the next step. And I think the decision collectively is let's not change too much, too many times. So we'll probably make one more change before we would have to be prepared for the potential of another fall surge of viruses. Next slide, please. And a lot of this is because we feel there's enough population immunity, not just that COVID-19 is not surging at the moment. And this is some of the data that we have in Ontario about vaccine update, which is a little outdated. It doesn't get updated that frequently, but currently 14% of people 5 years and above have had a booster within the last 6 months. Now that sounds really low and concerning, but when you think about that, it's really not taking into account the fact that most people have had infections at this point in the pandemic as well. And so there's a lot of hybrid immunity, and so collectively, that's probably why we're seeing these kinds of trends. Next slide, please. Now, in terms of boosters, the NACI, or the National Advisory Committee on Immunization, is really our go-to source for recommendations. And they did put something out on March the 4th, I believe, that was an update to the booster recommendations for this spring. Next slide, please. The real focus is on people who are at risk for COVID-19 adverse outcomes. Now, they do still recommend that those over the age of 5 or above should be immunized with a primary series of an mRNA vaccine, and those between 6 months and under 5 years of age may be immunized. So it's a little less of a strong recommendations for that younger age group. For individuals who hadn't previously had their recommended doses, like the primary series or the boosters that were recommended in the fall, they should get their booster dose at that time or their primary series. So that's kind of the baseline recommendation for everyone. And then in terms of further boosters, this is where it's interesting. It's actually not a hard and fast recommendation for most groups, except for those over the age of 80. So the highest risk groups, the recommendation is still there 6 months after your last infection or dose, to have a booster dose. Adult residents of long-term care, other congregate settings who are also high risk, it is recommended. And then those over the age of 18 who have moderately or severe immune compromise due to underlying condition or treatment. And then those who are sort of in that 65 to 79 age group, if they haven't had a prior history of infection, and if they have any of these high-risk features in particular, they would be recommended. So it's really focusing on the highest risk. And for everybody else, it's a bit more of a decision that people would make personally about their risk and their level of concern. Next slide, please. Now, I just wanted to end off here talking a little bit about some of the other respiratory viruses and prevention. Again, I wanted to be able to share uptake data on influenza vaccination for this past season with you, but unfortunately, after lots of digging, I was unable to secure any of that information. It's not yet available for the province or even for the City of Toronto, so I can't show you even regional data. But I can tell you that on the front of RSV vaccines, there have been some developments, not in Canada yet, but in the US, the FDA did approve a Pfizer vaccine, RXV, for prevention of lower respiratory tract infection in adults over the age of 60. And this was involving a study that's still ongoing that had 25,000 participants. They're going to continue the study for at least 3 seasons of RSV. And what they found in the original study is an 83% reduction in lower respiratory tract infection, 94% reduction in severe lower respiratory tract infection in this population that was studied. And there have been some other additional small studies that have been supportive of this vaccine. Very few side effects that have been mostly minor, although there were cases of ADEM and Guillain-Barré syndrome that were reported. And those were in those who received other vaccines at the same time. And then on May the 18th, the FDA was convening, and I haven't heard the outcome of this yet, but it may be out soon, to review a maternal RSV vaccine that is geared to try and prevent severe infections in newborns, neonates. And this study has shown an 82% effectiveness in preventing severe lower tract infection in newborns in the first 3 months, and it's down to 69%, which is still, moderately to highly effective at the 6-month point, and thereafter it seems to wane substantially, and it's considered very safe, with a slight signal towards increased preterm labor in the clinical trial. Although I'll say that looking at these numbers, they're already below, even with a placebo, what the baseline level of preterm labor would be with their definition. And so I think this is where I stop as a quick synopsis. I'm going to hand it over to you, Ali.
Sounds good. Thank you so much. So we actually have quite a few questions in the Q&A. So we'll turn things over to the Q&A. I'm going to start with one of the most upvoted questions here, which goes back a little bit to what you were talking about with the changes in guidance around wearing masks. And specifically, the question is, in indoor settings, and perhaps even non-hospital settings, such as like schools, for example, when is it safe to be maskless?
So again, this is a really tough decision because it really does reflect on our levels of, risk tolerance. And I would say, at this point, we're not seeing as much COVID-19 circulating. So the chances of coming across it are much lower. And so depending on your own sort of medical conditions and your own risk factors, this would be the time, if you were comfortable with it, to not wear masks. And, I think we do have to balance this with feasibility and the other impacts of masking in environments like schools. So, I think it is reasonable for schools to be maskless at this point in time. If we face surges of COVID-19, then that may need to be considered, especially if there is a new variant that would come to the front that is quite immune evasive or causing, changes in characteristics of what we're seeing with COVID-19 that would be concerning. At this point, there isn't something on the horizon that seems to be behaving that way. So, I think that this, again, always comes down to how comfortable you are with it. And you should never feel uncomfortable wearing a mask in an indoor setting with other people around. But, I think that what people are doing right now is not unreasonable. And we have not seen on a population level negative impacts of, lack of masking in indoor settings at this stage right now.
Thanks so much for that. Next question is, someone's wondering about whether there are any studies talking about repeated COVID-19 infections and whether, are there any other notable outcomes apart from a heightened risk of long COVID?
Yes, there have been many different studies trying to understand what the overall impacts are of repeated infections, and I'll say they're quite mixed in their outcomes, and I'm not really sure how to interpret the data. Aside from what was mentioned there, I think we do know that unfortunately, it's not like you're exempt from getting a long, post-COVID syndrome because you've had it once and you got through it scot-free. It's sort of, these are independent events, unfortunately. So cumulatively, you do have an increased risk. I do think that we're going to be, 10, 20 years out from this before we truly understand what some of those impacts are immunologically and to the rest of your health with repeated COVID-19 infections. So not a very satisfying answer, but that's where we're at right now.
Well, thanks so much for that. Another question is around mandatory masking, because, you definitely went over, the hospital protocols and the hospital recommendations, but we have an audience here with a lot of people who work in outpatient family medicine offices and waiting rooms. So a lot of questions here around, what are the recommendations for mandatory masking in those types of settings in an outpatient office?
It's a really tricky one, isn't it? And I'll say, I'm struggling with these decisions that we're trying to make on a regional basis. There are really disparate views on what we should be doing still at this stage. And I would say, there's a lot that is lost without having that sort of ability to see your patient fully. And some people who've already moved. So there are some areas like the west regions of Ontario where they've already moved to only masking for, or they will be moving very soon to only masking for if somebody fails a point of care risk assessment, but otherwise masking for direct patient care in inpatient settings. And then in some ambulatory settings, they've already stopped. And the feedback has been very positive for that kind of approach. I think it's still weighing the risks. It depends on what your practice is going to be. If you have a lot of immune compromised patients, you may want to consider keeping the masking going. If you have a very elderly population that you see, you may want to consider keeping masking going. Many other settings like mental health clinics, things like that, have found it very difficult to maintain their practice with masking. So outpatient settings, I feel like there's not one size fits all kind of rule for that. It really does depend on your population. That's kind of how I would approach it. Now, I will say in the Toronto region, so know what your regional recommendations are. I think right now it's probably a bit mixed, but you should realize that in hospitals, at least, we have maintained masking for all direct patient care and all clinical areas, basically, for now at least. And so, I think it helps as well to understand if your practice is near a hospital and people are going back and forth, that consistency is important for patients too. So it is really dependent upon your patient population. What is the best approach for masking?
Thanks for that. And something that goes along with that a little bit too is we have some physicians here that also work in long-term care, and to my knowledge, there hasn't necessarily been new guidance on that. Are you aware of anything that's coming down the pipeline for long-term care settings specifically, or what's in place right now?
I haven't heard of anything changing yet with long-term care. So I think that recognizing, again, it's a congregate setting with a lot of high-risk individuals, probably will be maintained for a while. And certainly once we get into the fall, we should all be ready to have to shift back into more masking if necessary. So I agree, if you're working in these multiple settings, you should consider that risk as well. It's shifted a little bit to really kind of protecting your patients that you're dealing with immediately, and that's really the justification. But we know that from the data, the more individuals that are masked in an environment in total, the additive effect, the effects are additive. So it's there's a bit of a middle ground approach that's in place right now, just to try and satisfy all the different pressures that everyone's experiencing, including a lot of complaints that people are getting from the staff working in hospitals, who are finding it now actually quite cumbersome to complete their shifts wearing a mask. So these are all the things that are going into the decision making, along with the population immunity, et cetera.
Thanks so much for that. It's helpful to get some insight as to how these decisions are made. The next question here is, someone had quoted some of the data that they're seeing about infections per week in Ontario. So they said that there was 177,000 to 245,000 COVID infections this past week, which would equate to almost 1 in 41 Ontarians. Is that data true? They found this on Twitter from one of the physicians based out of the university.
I would kind of turn it back to you and say, does that seem true to you? Like, I mean, that sounds very high to me. These are modeling estimates. And I know that Dr. Moriarty has put out lots of data through the pandemic that's been very, very useful. But I find that really difficult to reconcile with what I'm actually seeing out there. I'm not sure how that estimate was derived. I'd have to go back to her estimates and how she's been doing it. But that really is not reflecting what I'm seeing and what I presented in the beginning of the presentation on percent positivity of those tested, as well as what the wastewater is looking like.
Yeah, it's definitely very curious for sure. Now, the next question here is about vaccine effectiveness. So there's been some questions about this. So what is the effectiveness of the vaccine at 3 months and 6 months out for both infection or severe disease? Do you have any of those numbers?
So some of this is available. Actually, if you want to get more detailed data, and it's escaping my mind at the moment what the actual figures are, but the National Advisory Committee on Immunization, the NACI updates, will always, in their latest iterations, review what the effectiveness data is showing. And it's becoming more and more difficult to actually summarize that because of all the shifting variants that have occurred over time, and not being able to always collect infection data from individuals in the population because people are not PCR testing anymore, right? So there's rapid testing available, people are not testing, period. So we don't have a great sense of how to actually calculate this without accounting for some of these other features. But I would say go take a look at that, because that's where you're going to find your latest data. I think we know that the vaccines that we have currently are unfortunately of moderate and in some cases low effectiveness. And the recommendations that the bivalent boosters are a better choice than the original vaccines that were available for boosting, et cetera. So be aware of what those are. But the other thing is that you can't always measure in antibody studies, for example, that have been used to derive this, what the true immunity is going to be at these different time points. So be cautious about what you're reading about immunity-based studies alone, like antibody-based studies alone.
Thanks so much for that. Now, on the subject of vaccines, there's been some questions too about recommendations for kids under 5. Any thoughts at all about that?
Yes, like I had mentioned in the presentation, NACI has actually had a much weaker recommendation. It's a sort of a may consider for those under the age of 5. And that is related to a couple of things. The risk of severe infection is much lower in that age group. The risk of infection has actually not been that high either. And so weighing all that with the fact that you're, talking about giving multiple vaccine doses to these young children, this was a decision that was made in the end. And I think it's reflected too by the uptake. I think in the under 5 years of age group, only 5.2% of children in Ontario have had that primary series. And yet, we're not seeing a lot of harm from this, right? I mean, we haven't seen very many cases in young children, certainly not ending up requiring hospitalization. Again, this is all with the caveat that we don't know what the long-term effects are when young children are infected with COVID-19, especially multiple times. This came up in another question. But again, I think we do have to be rational about weighing these risks and benefits very carefully.
Thanks for that really balanced answer. I think that's helpful. And interestingly, yeah, there was a question a bit about NACI, and I'm curious if you have any thoughts on this one. So, the question here is that NACI recommendations appear to be based on the risk of hospitalization and deaths, but, is there consideration that's actually given to boosters to prevent post-acute COVID syndrome, or preventing some of these other risks that you talked about earlier in terms of other, adverse outcomes of COVID? Is that factored in at all into that process?
It is, and NACI does outline their rationale for decision-making, which includes effectiveness data for what we know the vaccine can target. And unfortunately, we don't have the greatest data for all of these different endpoints that we'd like to know about, but whatever is available with that, but also taking a bit of an ethical lens, an equity lens, a feasibility lens as well. And the adverse event monitoring is part of this as well. So it does take into account all those different things, which is why some of the recommendations come out sounding a bit loosey-goosey, but it's because it's not an easy thing to always weigh. And so, it can be a bit surprising to people that it's not always black and white, but we're still in a gray zone when it comes to what is the long-term plan for booster doses with COVID-19.
And I'm going to switch gears here a little bit for one question that's quite popular. And I know you had mentioned, it's important to think about other diseases in addition to COVID at this stage. So the question is about strep throat. And someone mentioned that they're seeing significantly more positive strep throat. And some of you may have also seen the memo that came out, I believe, a few days ago that was asking all of us to monitor more for Group A strep. Do you have any thoughts on this, or any data or explanations for the rise in strep throat that we're seeing?
Yeah, this is actually really interesting. This has come up quite a bit in the last little while. We are seeing more people hospitalized with severe invasive group strep as well right now. And this is actually a global phenomenon. It's not just within Ontario, although we've definitely been seeing it here since January in Ontario. There is a Public Health Ontario report that summarizes some of the data. It's more epidemiologic data compared to previous seasons, showing that this is clearly more than what we normally see. But I haven't been able to find the clinical data. And actually a colleague of yours that had reached out and asked for that, we were kind of back and forth yesterday, and I will be asking to see if there's anything more to guide, what kinds of presentations are people coming in with? And, are there any trends in terms of, progression to severe disease in any of these individuals. I will see in the hospital, what we've been seeing is more sepsis, bacteremias, some skin and soft tissue infections that are severe, but mostly the sepsis cases coming in quite ill. So, I mean, I think this is a trend we need to watch very carefully. And in primary care, you will see a lot of strep throat probably in the next little while. Be on the lookout for that and ensure that you're aware of how to actually test people for this correctly, so we can distinguish between them, and making sure that reporting any invasive group A strep according to the Ontario protocols to public health is going to be really important, so we can see what happens with those trends. There isn't an M type. Like, we look at the serotypes of the group A strep to see if there's a change in the, so to speak, strain that is circulating, if there's something that's causing more severe disease or more aggressive disease. And it is still mixed, and that is in the Public Health Ontario report if you're interested in seeing it. So it's not like it's being driven by some change in the feature of the organism itself.
Great. Thank you so much for that. And so with that, I think I'll start moving things along to the next portion of our community of practice. But thank you again, Dr. Hota. And there's still some more questions in the Q&A. So if you want to type out answers to those as well, please feel free. Before we move on to the ChatGPT section and introduce you to those panelists, I wanted to just give a brief update on an announcement that came from the Ministry of Health yesterday. So the Ministry of Health has established community-based remdesivir pathways for treatment of COVID-19 through home and community care support services. There are 14 branches across Ontario, and the majority of those regions are participating in this program. So if you do have a patient who requires remdesivir, they can be referred to their local home and community care services branch. And there's a form and that you would submit, and then the care coordinators will follow up with the patient. In most cases, the patients can receive the infusions at the community nursing clinic that these service providers run. But if required, they can also provide the infusion at home. Next slide. So in terms of this program, it's a very new announcement. So if you do have questions about it, please contact the individuals that are listed here on this slide. And as a reminder, these slides will be circulated, so you'll have access to this. Next slide, please. The other announcement that came out from the Ministry of Health is that just a reminder about Paxlovid drug interaction, specifically for patients who are transplant recipients. And so one of the serious adverse events that's reported in terms of a drug-drug interaction is with tacrolimus. And so Ontario Health is advising that transplant patients should not take Paxlovid without first speaking to their transplant care team. So they had sent this out as a reminder for doing so. There's also some resources that you can consult if you're prescribing Paxlovid and you aren't sure about the drug interactions, which are also hyperlinked in that announcement. Next slide. So I'm very pleased to turn things over to Anne to get us started with the ChatGPT topic. Over to you.
Thank you so much, Ali. Good morning, everybody. I'm going to dive right in the interest of time. So can I have the next slide, please? Okay, so ChatGPT, what on earth even is it? So ChatGPT is a specific proprietary product available for free or paid use that was developed by a company called OpenAI. It was launched in November 2022 and is therefore just celebrating its 6-month birthday. So it's based on a specific proprietary artificial intelligence model called GPT, which stands for Generative Pre-trained Transformer. So OpenAI developed ChatGPT as a chat interface that sits over the GPT AI model. So GPT is a large language model, otherwise known as an LLM. LLMs are a type of AI, a generative AI, that use natural language processing. So LLMs use content they've been trained on to generate original content that resembles human writing. So GPT was trained on information from the internet up until September 2021. And the AI jargon for this is time-boxed, in that it has a time limit where it hasn't been comprehensively trained on information after September 2021. So its purpose as a large language model is to produce a realistic and persuasive output. And autocorrect is an example of natural language processing that we all use every day. So next slide, please. All right, so that's what it is. What isn't it? So it's not a search engine. A search engine indexes web pages and directs users to specific pages that the algorithm identifies as relevant based on their search terms. So not only is the information contained within ChatGPT not indexed, ChatGPT is actually not connected to the internet at all. It was trained on large swaths of the internet up until 2021, but it does not have the ability to search the internet for information. Caveat, a few corporations like Microsoft and Google have started to add ChatGPT functionality as companions to their search engines, which is out of scope for this talk, but happy to dive into that in a future session. So lastly, it's not an encyclopedia or an answer finding device. It's a language production device. So it's designed to create realistic outputs, but not to necessarily provide high quality information. A large language model, in essence, makes up content based on what words it thinks are likely to go together, given its training data and the context from the prompt that it's given. So a large language model does not know if its outputs are true or false. Next slide, please. Okay, so putting this all together, a language processing machine learning tool, time backs to 2021, not indexed, not connected to the internet. What does this mean? So the first implication is for accuracy. So the current version, which is number 4, GPT-4, is much more accurate than its predecessors. And here in the graph, it is the green bar. So depending on the topic, it's accurate between 70 and 80% of the time. So therefore, with something that's accurate, with something that's inaccurate, 20 to 30% of the time, there are safety behaviors for its use that we can employ to mitigate the limitations. Next slide, please. All right, so the most important for us to understand when thinking about ChatGPT is this phrase that's common in AI, which is called human in the loop. So this is from the creators of ChatGPT and their safety best practices. And they recommend that in high stakes domains, like medicine, users just need to do a couple of things. And one is just be aware of the limitations. And the second is to be a human or have a human in the loop and verify the outputs. So simple enough. Let's look at a few examples of what the limitations can look like in practice. So you can start to get a sense of how you might want to use ChatGPT and how to do so safely. My examples are going to be looking at the limitations, and then Dr. Pana is going to take you through a bunch of examples of how he's been really finding it valuable in practice. All right, next slide, please. Okay, so for the first limitation, which is the time boxing. Oh, sorry, will you go back a slide? Thank you. All right, so if it was trained up until 2021, what happens if you ask it information about things that have changed since then? So yesterday, I asked it a little trick question about Evusheld, and this is the answer that it gave. And I apologize if anybody's listening in on the phone because I'm not going to read these answers out. But it basically said, I don't know, I'm a mere machine. You should go ask a reputable source. So that was yesterday. If you'll go to the next slide, this is what happened when I asked the same question a month ago. So yikes. Okay, it did a couple things, and this is showing some of the other limitations. So the first is that this is what machine learning looks like in practice in real time. So this means that the answers that you get from ChatGPT can differ widely based on not only when you ask, but how you ask your questions and prompts. So as you can see in this example, I asked it about Evusheld, which at that time it was a little confused and it thought that it was an opioid medication. And then I asked it about the generic name, which I will not embarrass myself by trying to pronounce on this talk. That one it could identify, but because it was time boxed, it was giving out of date information. So this shows a second limitation, which is that it's a language creator, not a fact finder. So for those 1 out of 5 times when it's inaccurate, this is what it looks like. So this is a program that's meant to produce realistic and persuasive language based on a large pool of kind of blended up information, which is exactly why the safety measures are important. Next slide, please. So this example, which is an anecdotal example from the internet, from Medium, it paints a bit of a grimmer picture, but it highlights just a couple of important things for us to remember. So the first thing is that ChatGPT was not developed as a clinical decision aid. So if it's being used in that context, it should be with caution and by experts who can identify incomplete or inaccurate information. So in this example, an ER doctor finished his shift and then he went and fed a bunch of his cases into ChatGPT to see how it did. And this one example he gives is of a 21-year-old female patient who actually had an ectopic pregnancy, but ChatGPT didn't include pregnancy or ectopic pregnancy at all in any differential diagnosis. And what was his main concern was actually the idea that patients would be using ChatGPT to diagnose themselves rather than see a physician. And that's where he saw the most concern. So there is a real need and a role for all of us to play in patient education about ChatGPT. So the simple rule of thumb that I've seen repeated over and over is just don't ask it anything you don't know or that you can't verify. All right, next slide, please. Okay, so this example is of a clinician who's writing up a SOAP note or asking ChatGPT to write up a SOAP note for them. So this shows us an example of hallucination. And so ChatGPT can be extremely useful for language generation tasks because that's what it's made to do. And Dr. Pun is going to go into a lot more detail about its value on this side. So it's a great example of the kind of output you can ask it to create. And it's an example of a hallucination, which is something that you all might have heard about in terms of like ChatGPT in the media. So hallucination is a bit of a euphemistic term. So a large language model is designed to create original content. Hallucination as a word kind of seems to suggest that something abnormal is happening. But in fact, a hallucination is not an example of ChatGPT malfunctioning. In fact, this is it doing exactly what it's designed to do. So that's to generate original content based on its training data and on its prompts. So in this case of the SOAP note, it's a little bit of a kind of fish gonna swim, birds gonna fly sort of thing. A generative AI is gonna generate. And so the clinician puts in a bunch of specific details, asks ChatGPT to write up a SOAP note, which ChatGPT does, but it makes an addition. It adds this bit about abdominal tenderness on physical examination. And it's done that based on including a symptom that would often be seen probably in its training data in a circumstance like this. However, it was not true for this patient. So this is a great example of why you have a human in the loop. You would just verify the output, take out anything that wasn't accurate to this patient's visit, and then you've saved yourself a little bit of time in creating the whole note. Next slide, please. Okay. So just in sum, it's extremely useful for all these things, and Dr. Pun is going to go into them. Any kind of language content generation things. We would proceed with caution with GPT-4 for using it as a diagnostic tool or clinical decision support aid because of the limitations of the software, of the model. And we would ideally avoid it for patient information seeking, or if you're seeking authoritative guidance, if you just want to ask it, what does Diabetes Canada say about this? It won't be able to tell you. So rules of thumb, human in the loop. Don't ask anything ChatGPT, don't ask it anything you don't know or can't verify. Next slide, please. So these are just a few comments about beyond ChatGPT, what is sort of happening and what we'll all be seeing in the near future and what we can be looking out for of AI tools that will make them particularly robust for the healthcare context. So that will include tools developed specifically for medical practice by medical practitioners and experts. Tools that work within the limitations of the large language model to give it specific language-based tasks. So something like AI Scribe would be an example. And then any additional layers put on top of a large language model, such as filters that allow you to select what type of information you want to see, a semantic search, which is more about identifying relevant information, and then any augmented retrieval kind of thing that helps you identify that helps the tool identify sources and then draws content only from that. So those are a few things, but there is one area in which the current version of ChatGPT really excels. And so if I can have the next slide, this is the community of practice blurb that I asked ChatGPT to write in the style of the Chaucerian epic. And it really outdid itself, in my opinion. So I will leave it there. Thank you, everybody, very much. And I look forward to hearing the discussion.
Great, thank you so much, and especially for that one there. I think maybe we can start reading that out every day. We can read a section at each community of practice in the future. So thank you so much for that one, Anne. And thank you for that wonderful presentation too. And I wanted to just mention to the group before we turn things over to Ian is that, part of our thoughts around organizing this session is that we wanted to ensure people understood what ChatGPT was, and Anne provided a really great overview of that today. And also understand too, what are the benefits, but also the drawbacks, and what are the things that we have to think about, especially in a clinical environment, and ensure that we're thinking about this from multiple ranges of perspectives. So really grateful for that perspective today, Anne. You gave us a lot to think about. And now I'm going to turn things over to Ian to give a bit more of a dive into how this could work in your workflow and your practice. So over to you, Ian, and then we'll take questions from the Q&A. So I encourage all of you to continue submitting questions on this topic.
Thanks, Ali. So I'm a family physician and I'm practicing in Scarborough. Next slide. So today I'm just going to show you the actual technical ways of using ChatGPT, how to use a ChatGPT prompting. That's how you ask a question in ChatGPT. And I'm going to give you some sample prompts that I actually use in my medical practice. And of course, how limited the answers I get. Next slide, please. So Anne already dived into it, what ChatGPT is. It's a large language model. You can ask it anything because it knows everything off the internet, and it'll tell you everything that it knows. It's pretty reasonable. It's pretty intelligent. So next slide, we'll deep dive into this. So in order to use ChatGPT correctly and effectively, you have to ask it the medical context first. So in your ChatGPT box, when you ask the question, you have to say, I'm a doctor, okay? That will put it in the medical context that you're a doctor, you want to get some medical information. Second step, you have to ask it a command, okay? So in this example, I'm a doctor, please explain the lab, okay? Step 3, give it some data after the command. So in this example, I say hemoglobin 90, hemoglobin 27, MCV of 80. So let's put this prompt I just generated into ChatGPT. Next slide. So ChatGPT will analyze this prompt and will give you an answer. It'll say this patient's lab results indicate anemia. And then it will also analyze, it'll know that when you say HB of 90, it knows it's talking about hemoglobin. And hemoglobin 90, it knows that it's out of range and it's low. Same with hematocrit. It knows that HCV means hematocrit. And it knows that 27% hematocrit is low as well. So it can conclude that this patient has anemia. Next slide. it knows that the MCV is 80, but 80 is still kind of normal. ChatGPT also knows that it's low normal. So this is the incredible thing about it. So because of all these values being low, it can conclude that this patient has microcytic anemia. And that is sort of a mind-blowing thing when I first used ChatGPT. So it's almost like the first step of general AI. Of course, it's just a large language model. It associates different words all together to build these things. It's called a generative transformer. And this is a big technology. It's a breakthrough. So it can also know that because it's microcytic anemia, it'll give you some causes. So it associates that with iron deficiency, thalassemia. Okay, so this is a powerful tool we could use. Next slide. So here's a practical tip for you. If you want to copy paste your labs into ChatGPT, you don't have to type it out. You could just go to EMR and just copy paste the whole bunch of labs in your EMR. Just don't copy paste the personal health information like the health cards and birth date. And you could ask GPT how to analyze it. Next slide. So ChatGPT can actually take a history. So this is how you could do it. You could say, I'm a doctor, patient comes with stomach pain, ask the history questions pertaining to stomach pain. So ChatGPT will give you a list of long questions. Okay, it'll give you like 20 questions you could ask the patient. So it generates these lists of long questions. Okay, it's just like using your template in your EMR, but this is like a dynamic template. You could ask it to generate all types of templates on the fly. You have to kind of vet it and make sure it's good. So even with the stomach pain template answers, it even goes through the red flag symptoms like weight loss and blood and stool, etc. So you could use this template, answer it in front of the patient, say, can you describe the pain? Answer it with yes. How long has the pain been? Like 4 months. So you could go on and answer these questions. Next slide. Put all those questions and answers and feed it back to the ChatGPT in a message box. And ChatGPT will summarize this for you. Remember to use the word summarize, okay? Don't use the word create, or else it's going to make, like Anne said, all the physicals and stuff like that, make stuff up for you. So if you do this, ChatGPT will write in sentences and collate all that information. And even though the information may be here and there, it'll actually organize the information too for you, okay? So this patient has stomach pain for 4 months. So and so on, as you saw in the history over there. Next slide. Another clinical use case is Anne telling me that, okay, that ER doctor missed the ectopic pregnancy in the differential diagnosis. But it's really how you prompt the ChatGPT. So when I did this, 21-year-old woman with right lower quadrant pain, what's a differential diagnosis? ChatGPT gives me like 10 different diagnoses, and it was correct. It was appendicitis, ovarian cyst, ectopic pregnancy. It knows, it's like a very smart medical student. It knows a lot of stuff. Okay, so in terms of maybe diagnosis of sort of strange patient you don't know, you would kind of ask it. Of course, you could Google this stuff, but this ChatGPT, of course, Google gives you a lot of ads too. ChatGPT just gives you a big long list, a little bit more focused. But of course, you got to vet it. You have to kind of be like an expert, a physician clinically to know that it's not bullshitting you. Okay, so I'm going to run through. I got 4 minutes left, so let's next slide. So I'm going to clinical decision making. So I asked if ChatGPT treatment of H. pylori 11 days isn't enough because the patient is supposed to take 2 weeks of H. pylori quad therapy treatment of 2 weeks, but due to side effects of vomiting, you only take 11 days. So ChatGPT actually said 11 days is probably enough in some studies, but I had to fact check this. Next slide. So the e-consult that I did with an ID specialist said it is enough in some studies. But of course, the specialist it has more insight compared to ChatGPT, because it tells me to repeat the urine breath test in 46 weeks and have other types of treatment when if it doesn't work. So you really, when you use ChatGPT, you really have to fact check this. And you kind of have to be an expert to know that it's not really pulling your leg. Next slide. So you could do it for patient counseling. You could say, list me contraceptive options for women age 30, and it'll list up the whole bunch of contraceptives options. ChatGPT will give you a whole list. It's great at generating lists, okay? But of course, you always have to fact check this as well. Next slide. So, if you take anything away from this ChatGPT, if you're afraid of putting too much personal or sort of proprietary information, or your chats are too sensitive or something, you could always delete your chats and export it. It can, you could email those chats to your email, and then you could just erase it from your chat history. Next slide. So ChatGPT can extract meds. If you have a whole long list of facts or something, you could tell ChatGPT to just export the names of the medication and dosages. So it really can save your time from retyping everything. So you could just copy paste the facts, your facts that's OCR'd, right? You just put it into the ChatGPT and say, extract the drugs and dosages, each one a separate line, and it'll give it to you right there. Next slide. So letter writing. You could write emails to your lawyers, insurance companies. If you want flowery letters, formal letters, just tell ChatGPT to write one. I've used this to write letters to lawyers and insurance companies, disability letters. So just say, write a lawyer to a letter, thanking him for the payment of the chart. And ChatGPT will write this for you, as you can see here. Okay, next slide. So report ministry, letter to ministry, same. You could say this patient has a recovered from alcohol addiction. So you could have it write a letter. Of course, it writes a very formal, very wordy letter. You're gonna have to edit it. So it's a great tool. So instead of me telling you what these things do, just go to ChatGPT and try it yourself. You'll be amazed if you've never tried it. You can have it write poems and lyrics and things like that too for fun. Okay, next slide. Because I'm administrator of Oscar EMR Ontario, I show people how to write queries to data mine their EMR. I've been using ChatGPT myself because I have a background in computer science. I use ChatGPT to write queries and even basic apps. It's amazing. So that's really beyond the scope of this. So this is something you have to look out for. Next slide. So in conclusion, ChatGPT has limits too. So of course it doesn't have, it's not a doctor, it's a language model, it's a program, it's not sentient, it's not alive, it's a machine, okay? So it doesn't have medical judgment like a real doctor, okay? It can't do a physical exam. So as I showed you, the human expert was more insightful, the one with the H. pylori treatment. So it's trained until 2021. Of course, it doesn't know anything about Omicron COVID. Okay, it can misinterpret context, but you have to provide the correct prompt for it. Privacy concerns, yes, it goes to the server and you have to go to this big neural net to process, all right? So don't copy any patient names and health cards and birthdays into it. You could just copy just the signs and symptoms of the patient, or nothing really too personal. So bias, hallucinations, misinformation. I haven't found ChatGPT in my last 6 months of using it that really tells you to do something very dangerous or to do something. There's always a disclaimer saying, see a doctor, and saying, I'm not a doctor, I'm just a large language model. So you have to take a grain of salt. Next slide. So there's other companies that are actually making large language models. And I think there's other models that we have to look out for are these open source ones that are coming up by Facebook and stuff. It's going to, ChatGPT is actually still the best one available, but these models are quickly catching up. Next slide. So Jeff Hilton, he's a Turing Award winner. He's the godfather of AI. He's a professor at UT, and he says that for family doctors using AI, you're going to be much better family doctors. Next slide. So use ChatGPT. Use this prompt here. So just put ChatGPT, I'm a family care physician, generate more prompts for me to increase efficiency, improve patient care, and reduce own burnout. So that's all I have to say. Because next slide. So control the AI. You have a Terminator here. We have to reprogram it and use it to our own advantage. That's all I have to say. Thank you.
Thanks so much, Ian. And those images are AI generated, right?
Yeah, they're standard by another AI called Stable Diffusion. I just put this prompt in, Stable Diffusion, have Terminator treat patients using EMR. So Arnold Terminator is interviewing Linda Hamilton there and using the EMR. I think he's using Acuro. I don't know.
I can see the frustration in his face, so I think he must be.
Yes, he's burning out.
Yes. Okay, perfect. Well, thank you so much for that talk. Now, one thing before we move into the Q&A, I think I just wanted to reiterate, just because I think we heard it a few times here, is that ChatGPT, and even in the chat we're seeing it as well, is something that's here. It's something that potentially is a tool for certain aspects, but at the same time, I think it's something that we're still trying to figure out, like, does it even have a role in our practices in the first place? And is it safe? Is it medical legally appropriate to be using it as well? And so I think this is an emerging topic that's going to continue to be explored, I think, as time goes on. And I just wanted to reiterate that as the community of practice, we're really trying to just explore these types of issues in our practices, try and see, are there ways that we can address some of the administrative burdens and the things that we deal with day to day in our practices. But we also want to make it very clear that we're not necessarily recommending that everyone goes out and uses ChatGPT, but just thinks about it. And hopefully today's discussion has prompted some of that discussion. And make sure as well that if you do choose to use it, that you are following best practices, both in terms of avoiding, as you both said, using it for diagnostic purposes, remembering that, we're trained as physicians for a reason, and that, we need to use our brains as well. And it's very important that we're continuing to do that, to do right by our patients, and also avoiding any potential privacy breaches by putting personal health information into ChatGPT. So I just wanted to reiterate some of those points as well, and just make sure that our audience is clear that it's not a recommendation coming from us today to use it, but really just to explore it today. So with that, I'll turn things over to the Q&A. And I think there's one question, actually, Ian, that you wanted to answer live, which is that it takes a huge amount of data to train ChatGPT. And it seems to me that there may be copyright infringement as the software programs search all over the internet for data and use it without specific permission. I think there are concerns with original medical research being used without permission and further erosion in the trust of that data. So I'll turn things over to you, Ian, if you want to say something, and also Anne, if you want to comment on that. I know you have a background as a librarian as well. So if you want to comment on that, feel free.
I think, yes, I think this is an issue with Stable Diffusion using artists training their data from their art. So I don't see it as much of a problem for medical scientific data, because ChatGPT will try to quote it, but a lot of times it's making stuff up. So I don't see it as an issue, as much as an issue with science and medicine, as opposed to art. Besides proprietary data, you really can't ask ChatGPT about it anyway. Even ChatGPT doesn't tell you how it does it, how it trains the stuff fully. So
that's true. Yeah. So the way it works, it really is kind of a blender. So even if you asked it a specific question where you know that a paper that you wrote would really inform the answer, what you'll get is kind of a mishmash, and you won't be able to even identify like a sentence that you can say that's absolutely taken from my paper, because it is sort of a real mix and match and blend of information is what comes out.
And then, Anne, I had a question for you as well. And just because I think there was a little bit of back and forth, and I wonder if it may be the different models of ChatGPT. Like, just to confirm, is there access to the internet for ChatGPT? Like, is it actually able to search? Because I think, Ian, you had mentioned that a little bit, but Anne, you had mentioned something else. So just for the clarity of our audience, could you guys clarify that for us?
Yes.
Sure.
Go ahead, Anne.
So yeah, the answer is extremely confusing. So if you go to the website that both Ian and I think have put in the chat at different times, which is the browser version of the research preview of ChatGPT, which is chat.openai.com, that is not connected to the internet. Where it can be connected to the internet is where certain other companies have started to pair it with search engines. So for instance, Microsoft's Bing search engine now has a ChatGPT functionality that is combining the two, and the same thing with Google's Bard, and that's exactly what it is. It's a marriage between that and a search engine. But if you're just going to chat.openai.com, which is where Dr. Pan and I were pulling all of our examples from, none of the answers used through the original ChatGPT in its little home will be pulled from the internet.
Yes. In my experience, ChatGPT just put on this sort of like a beta version that it can sort of browse the internet. It'll go to the website and it'll probably just searches that website, takes a text from it and try to analyze that website. Because ChatGPT, if you ask it, what time is it, it'll tell you the time and date. So it's kind of almost lying to you. But if you ask it something else, like what's the weather today in Toronto, it'll say, I don't know the weather today in Toronto. And if you say that, oh, just look on Weather Canada website and give it the URL, it will say, no, I can't search that. So ChatGPT has some type of, I think it's lying to you sometimes. So you could try to fool it, but I think it's getting more, you can't fool as much now. So there's ways of fooling it. I won't get into that right here.
And the fun and tragic thing for everybody who's listening and trying to understand ChatGPT, we're just really sorry, is that it changes all the time. It changes every day. So the things that were true today about how it works and the kind of answers it will give you and what it will answer and what it won't answer will be different next week. Because for a number of reasons. One, as we saw with the increase of the accuracy, the creators of ChatGPT itself are always trying to make it improve. It's a machine learning tool, so it's trying to learn and do better. At the same time, they don't have a plan to release a ChatGPT 5. So right now it's just 4, and that's where the plan is going to be. And there's no plan to extend the time. So it's just 2021 ChatGPT 4. And where we will see all the different changes and the things will get very confusing is now all of the different companies and all of the different API connections where they're going to include ChatGPT in something. So for instance, the search engines is a great example, which means that ChatGPT, if you use it over here, will have different functionality and different limitations than if you use it over here. I really feel sorry for all of us.
So I could comment on my experience with ChatGPT, looking for people asking, I think somebody asking drug interactions. It knows some of the major drug interactions, some of the more major common drug interactions, ChatGPT 3. ChatGPT 4 gets it more correct. Some of the more obscure drugs it may not know. So I wouldn't trust it for drug interactions. I also asked ChatGPT to calculate Framingham risk scores. ChatGPT 3 just messes it all up. It just really doesn't know how to count and assigns like different scores to the age. It just makes it all up. But ChatGPT 4 almost gets it correct, actually. It is amazing. It's really improved a lot, actually. So as physician, I think we have to vet this AI because this AI is getting better and better. With ChatGPT 5, with more and more parameters. Because ChatGPT 3 is 1.75 billion parameters. There's going to be larger AI models. Like Google has like 5 billion. And everybody's doing it now. It's only ChatGPT 3 is sort of mainstream, but all the other companies are doing it. Companies in China are doing it. Every company is doing it. And once you have the model, eventually in the future, you can run this ChatGPT model on your own laptop computer. And that's when it gets kind of scary. You're going to have like Terminators, okay? If they're going to put in the robots. So that's just more philosophical, but that's something exciting to look for. So we, as doctors, we really have to know this technology and not be afraid of it.
Thank you so much. I think that's a really great way to kind of sum up that discussion. Is that I think this is here. It's the future, and we're going to continue to see this evolve and come into our world. And as doctors, we need to think about how do we safely integrate this and use AI to support rather than impede our patient relationships and our patient care as well. And I think both of you really brought that message home today. So thank you for that. So next, I'm going to turn things back to our slide deck. We just have a few announcements from the OCFP. And I'll turn things over back to our OCFP president, Dr. Kuminen.
Thanks, Ali. I was just going to say, I think I'm pre-contemplative when it comes to ChatGPT right now. So I'll stick with what I know. I wanted to just give an update on some of the advocacy work that we've been doing at the OCFP. So many of you would have filled out the admin burden survey that was sent out last month. And we heard that 94% of you who responded to that survey wanted the OCFP to advocate to the OMA and SGFP specifically around our upcoming physician services agreement. And so we've responded in a number of ways. We've convened a working group and we are submitting recommendations to the OMA. You'll see on this slide a couple of bullet points that outline just at a high level some of what we've touched on. So we're hearing loudly and clearly from many of you that we need to look at increasing our compensation, specifically across all practice types and relative to specialists. We're also hearing that we need to look at ways to introduce compensation for unpaid admin work, of which we know we do a large amount week to week in family medicine. And then ultimately looking at ways to ensure that our compensation is matching the increased complexity that we are facing in family medicine. So in terms of next steps, we will be meeting with the OMA to present our submission for the Physician Services Agreement in June. And we'll continue as well to advocate for other system level supports that can't necessarily be done within the PSA, and we'll keep you updated on that work. Just two other points. So we'd also encourage you to, if you've not yet done so, to fill out the SGFP Payment Reform Working Group survey. You'll see the link at the bottom of this slide, and the deadline is today. So if you've not done that, I would really encourage you to do so. And then I'll just touch on the admin burden survey that many of you filled out. We will be bringing you more information with these results and how it will drive our advocacy efforts at the OCFP at our next COP. So that'll be in June. Next slide. And then just shifting gears a little bit, I wanted to provide just another update on the expressions of interest for the interprofessional primary care teams that the ministry is funding. So a couple of websites on here on this slide that you can see. So any information can be found at the Ontario Health website. And they are offering support through regional contacts, and you can see who your regional contact is on that site as well. We have previously shared information on May 11th, and that's on our website, and you may also have that in your inbox. And we've also at the OCFP created an expression of interest page to support you through the process if you're putting in an expression of interest yourself. And then final point, so the Ministry and Ontario Health hosted a technical webinar on May 18th. As of yesterday, we didn't yet have the link, but we will share that with you once it's available if you weren't able to attend. Okay, and back to you, Ali.
Great. Thank you so much for those updates. So again, just as a reminder, the webinar recording and the Q&A will be posted on the DFCM website in its usual location. So please make sure to check that out. And you'll also be given an email as well when that's up and ready for you. Our next Community of Practice will be held on June 16th, 2023. So please put that date into your calendars. Same time, same place on Zoom. So looking forward to seeing you all there. And again, I want to thank you all for your participation today, your enthusiasm, your wonderful questions, and hopefully it was an interesting and engaging session, and we're looking forward to seeing you next time. Please don't forget to fill out the survey so that way we know what to factor in for future sessions. Have a wonderful Friday and enjoy the nice weather. Take care, everyone.